When you got fresh wounds, just walk in the triangle or the angle. I don't know what we call it on two. Exactly.
Yeah.
In the hospital, it's being upright for 3 to 5 minutes, 3 to 5 times a day. When they don't need to exercise while they're in the hospital, but you can get them out of bed.
So, like the inpatients that we'll see with that, the most common surgery will be
gastric bypass.
How many days stay will it be if it's inpatient?
It's 1 to 2 nights for
so
80% of people. In Duluth, we send home about 15 to 20% after 1 night, about 70 to 80% after 2 nights, and about 10% stayed a 3rd night. If they're having lots of nausea, if they had a long way to travel, and I asked patients who were from more than 50 miles away to stay locally for a week. Doesn't mean they always did, but that first week while we talk about things are not healed in there, especially Canadians, I'm going to beg them to stay on this side of the border. And in Duluth, we had Thunder Bay, Ontario. We had patients from. I said, you cannot call me from the other side of the border and say, tell the Border Patrol to let me through. They don't they don't care. You know what I mean? What I say. They do their job. Nope, they do their job. I said, you could really be stuck over there. So.
Do you expect to have a fair number of Canadian patients?
I hope to have a lot of Canadian patients. A city the size of Vancouver. I don't know of a city the size of Vancouver in the U.S. that doesn't have 15 bariatric surgeons. Vancouver has 0 dedicated bariatric surgeons. There are a few who do a couple of cases a year from what I know. I don't know everybody up there, obviously. Vancouver Island, Victoria has 2 surgeons that do weight loss surgery, but they, I think, are limited to about 150, 200 a year. And that is something that a town the size of Arlington could be doing. So, yeah, I hope to be taking care of a lot of Canadians. That's why I hope to get the price low enough that it's not just the filthy rich, that we're actually taking care of people. And I do also, as an advocate, I'm hoping to get British Columbia to get their own programs going. I mean, that will ultimately make me a little slower, but there's enough people in just Skagit and Whatcom counties to keep me busy long term. But I would like to have an impact up there. I'd like to change, especially with this diabetes epidemic. British Columbia has 1 million people in it who were not born on the North American continent, 1 million immigrants, and they also have 1 million people, some of whom were born there, but of Asian, Indian and Chinese descent. And those are the folks who get diabetes at that lower BMI. So I think they have probably more risk than the average city of 3 million. So I hope to make an impact. I hope we can all make an impact. I think it'd be fun. I mean, just the cool thing about this is 2 or 3 times a year you will see me be out of control, anxious, stressed, like a trauma, run into the OR, somebody very sick. Not even that often, but I get worried that way. I sweat blood over these folks. It doesn't happen that often that people really have a bad outcome, but I worry all the time. But for the most part, it is the coolest service. Once you're going, yes, you may see somebody get sick every few months, but then you see 50 other people going through having minimal issues. Wound infection here, nausea there, gallbladder there. It's a joyful service to see the change and to see people, like me, like Shirley, coming in and saying,
I shop in regular clothes.
Yeah, and just
people tell me I've gotten too thin.
What they say the most, what people say the most often is, I'm glad my diabetes, this and that, that's all great. But the cool thing for most of us is we feel like we haven't felt in 20 years. We feel like we got our life back. Because I was 44 going on 60. You know what I mean? I didn't feel like a 44-year-old guy. I felt like a 60-year-old guy. And now I feel like a 35-year-old guy, Maybe I feel like a 44-year-old guy, I don't know. But it's certainly, I feel like I've gotten my life back. That's what's as important as anything. Even if I die at age 50, I mean, yes, we all want to get those extra years of life that obesity took away. We do want to live longer, but it's as much about the life in your years. A lot of folks who are suffering from obesity, some of the most compelling things I hear from the office are, one early lady I operated on said, she was in her 30s, I think she was 37, she's like, actually I think she was a snowshoer, this is in Minnesota, and she said, I'm getting left at home at the cabin. Her kids were like 7, 8, 9. Dad and the kids were going out because she could only go for 10 minutes and come back because she was 100 pounds overweight. She said, that's fine when I'm 70, That is not fine when I'm 37. I am not going to be left behind. I'm not going to be out of my family prematurely. That's what she wanted, to be able to do.
Well, I can't lose 2 pounds. I mean, I can't. I mean, I truly, I don't understand. I mean, maybe 2.
I didn't talk about medical weight management. I probably should for a minute, but this is, it's out of the spectrum. Medical weight management works in the short term. You can put anybody in boot camp or lock them in a room. Physics works. If we hold back food, you'll lose weight. The problem with medical weight management is it doesn't last. Weight starts coming back almost immediately. Now, how fast it comes back, it's usually a couple of years for people to be able to regain 50, 60 pounds, but it almost always does. I haven't seen any big things on like The Biggest Loser or whatever, but almost all those folks, the weight is almost all the way back within a couple of years. The only good paper we have is from the 50s, and it showed 399 out of 400 people at or above their their pre-diet weight within 2 years. And that means 1 out of 400 made it, and then they get a book written about them, and then the rest of us feel bad.
So why don't you just snip out the gallbladder while you're in there? If they're going to
Very good question.
go on to gallbladder.
Because 7 out of 10 people won't need their gallbladder out.
Oh, okay.
Of people who still have their gallbladder, a lot of folks who probably, of 10 people who take the surgery, 3 have already had their gallbladder out. But then if you take a group of 10 people who've never had their gallbladder out, about 3 will need their gallbladder out within the next 10 years. But 7 won't. And the problem with taking everybody's gallbladder out is you're adding risk for those 7 people with no benefit. The other tricky thing is if you get a bile leak, you don't know if it's leaking from the stomach or the cystic duct stump. Now, I haven't had that many bile leaks, so we do sometimes. And if somebody has gallbladder symptoms, or and we do sometimes, but not routinely. You know, sometimes you forget to look over there. You're just so focused. But a lot of programs got routine ultrasounds. Rotten gallbladder you'd see.
Yeah, somebody that would be coming to you anyways.
And a lot of programs do routine ultrasounds, but if somebody has just a few stones, the other thing is, so yeah, the other answer to that, Ruth, though, too, is of those 3 people who need their gallbladder out a year later, it's a nice time to sneak a look around at the gastric bypass anatomy and make sure they don't have an internal hernia. We can stitch it up. It's also a lot easier operation once you've lost 50 pounds to take your gallbladder out. I think the main thing for me is the risk of gallbladder surgery is common duct injury. Common duct injury results in death or liver transplant. That's bad stuff. If I waited 6 months and your risk of common duct injury went down from even 2 in 1,000 to 1 in 1,000, if you were my sister, I'd say, just wait. It'll be safe for 6 months from now. It's not that big an operation. You know what I mean? And you'll be healthier and more time on the table. So that's the thought behind it. That's why we don't do it routinely. But if somebody's having gallbladder problems, I don't want to go back post-op day 8 to take their gallbladder out. And so we will on those folks. And if they demand it and they had stones, I would absolutely do it. If they demanded it and they didn't have stones, I'd have to ask them. I would ask them some pointed questions about family history and risk benefit. I probably wouldn't say absolutely no, but that's the thinking behind it at least. 7 out of 10, there's really arguably risk without benefit. So, good question.
Sounds to me like there might be some special discharge teaching that we'll want to give these folks. And
There is and there's not, because it's our job to do all the discharge teaching even before they get there. However, there's nothing that makes it real like being there with the Band-Aids on. So, yeah, I'm going to have to this. Yeah, I'm going to have to that. And then you're in the bed and it's like, let's say again. So absolutely, you guys will be experts, but hopefully you will not have to be, if you're originating stuff, then we're doing something wrong. Now, some people will say, I never heard this before, and you know as well as I do. You can hear that from the nurse the shift before Ruth goes off and you come on. Well, Ruth didn't say any of that. You know, she didn't tell me about the PCA and it's sitting there. Of course she did, they forgot. So you guys definitely, it will be good to put people, on track and get them going in a good way.
it'd be nice for us at some point to know what the teaching is that
yeah.
they get pre-operatively, so we
This
can
is
help.
just the
reinforce it.
intro. This is not the one-time deal. This is the start. We will have pathways, protocols. Jillian, my medical assistant from over in the office, was here at the first one, and I told her she's a nursing student or nursing student to be, to come over here and get to know you guys. And one of our dietitians is going to be Rachel Akins. So she's in-house. We're getting pathways together, and we'll get you guys up to speed on that. So
And the first surgery is Friday?
Friday.
Which
Oh,
one?
what
Which
kind is it?
surgery are
It's going to
you
be a
doing?
sleeve,
Okay.
sleeve gastrectomy,
Yeah,
and a
man or
hiatal
woman?
hernia repair. I'm sorry?
Man or woman?
Lady.
Do you
And-
do,
No, you go ahead.
what percentage of are men, women of the surgeries that you
In the U.S., it's about 70-30, 70% women. And that varies a fair amount, but guys just tend not to view their weight as much of a problem. It isn't as much of a problem socially, definitely. And women tend to be in the healthcare stream more than men too. I mean, guys tend to, not see docs as much, and they tend to present with heart disease by dropping dead. It doesn't help. They don't get much warning, right? So, so that can be tricky. But I think we'll see more men coming, but they're harder to convince as well. So, yeah.
I have two questions. One is, are you doing the surgery every day? Like, are you doing like one? Or, I mean, I'm just trying to figure
Right
out.
now, I'm looking to be doing any surgeries, but yeah, we'll have.
Or is it gonna be just
we'll
like
have
a Monday
certain
and
days of the
Wednesday, or-
week. We'll have certain days of the week when I have operative time, block time. So at the beginning, it will probably be. I don't have any blocks right now, so everything is added in, and so it may be any given day of the week. Ultimately, I probably will have block time, and then that will be the main day. But we'll have to talk about what the floor needs in terms of management. But as you guys know, the world revolves around the OR. If they say we got Tuesday, then you guys are going to have, that's going to be tough.
Never mind. Just kidding.
Well, we
So the spine's going back to third?
What's that?
The spinal surgery
Spine's
is
on
going
third.
back to third?
We ended up in Duluth when I was really busy and I was down a partner operating 4 days a week. I mean, there's enough work out there once we get the word out, once patients are coming in, to be that busy. But it probably won't happen.
And
It takes a couple of years.
my second question is, are you doing any teaching outside, like in the community anywhere? Or?
As much as I can. Yeah.
Okay.
It's just getting started, but if you have community groups, especially diabetes groups or any group who wants to hear about it, that's the other thing I used to tell, especially nurses, but talking to docs as well. You guys are witnesses in the community. You have a babysitter or a cousin or a neighbor who expects you to be an expert at this, and not just because you're on 2 North, but even the labor and delivery nurses, people think, well, what do you know about this stuff? You guys will get hit up about where do I go? Who's doing this? Is it in town? And so you can give little mini information sessions as well. But I am definitely available to talk to groups.
Yeah, I think like you said, and it's the financing. That's the biggest part.
Well,
And
insurance pays more than people realize for more policies, and it's growing. And as we get Center of Excellence, which I didn't really talk about, that's as we get a Center of Excellence built, then Medicare will cover and Medicaid will cover.
they will?
Oh yes,
Wow.
Medicare covers. Medicare covers really well. The hospital that you operate at has to be a Center of Excellence. And I'm a COE surgeon in my old program, but now that I'm at a non-COE hospital, I got to kind of start over on that. But with the proper work, it won't take us more than a year to 18 months. And then we start getting the Medicaid and Medicare people who are the sicker, older people, and that's going to be a whole different trick. But, yeah.
I mean, that's kind of what your goal is, to kind of get all the insurance
And to get the
Yeah.
insurances that do cover to cover better. Because we can operate on Peace Health employees right now, just only certain ones of them, and not by the best evidence. Yeah. And we can operate on them for self-pay, but, yeah, that's
So are you doing the Roux-en-Y's laparoscopically as well?
laparoscopically 98%. Occasionally you have to go open on any operation.
On all of these, you're going to do all laparoscopy with leaves?
Yeah. Safety first, but yeah. Cool. Well, thank you guys very much. I talked way over, but
You still need to show us your old badge, though.
oh.